will be hosting our seminar and webinar today, Dr. Ted Smith. And Ted is into some very interesting work. He and I have been crossing paths for some time now, and through the work that's happening in Louisville. And you'll hear some of that in his talk today. Ted is a cognitive scientist by training, which is a I don't run into a lot of cognitive science in my work, but I know enough to know that they're very special people with a very special skill set that's definitely relevant to the work we do in health and in population health. It's a field that is kind of an amalgam of computer science, neuroscience, and psychology, and is a very valuable discipline for helping us understand how decisions get made, and especially how we can harness the power of technology and better meld that with human behavior to help people and systems make better decisions and choices in the health arena. So I think some of Ted's disciplinary training and expertise will be apparent in the work he talks about today. He's had an interesting career trajectory, and trained at Miami University, not far from where we are in Kentucky today. Did a postdoc at MIT, where a lot of cutting-edge cognitive science as well as health technology work has been happening over the years. More recently, his time in Kentucky, he spent some time working as the City of Louisville's Chief Innovations Officer and working in the civic engagement space. Has done that in recent years, and I think some of the work that he'll talk about today played out during that period of time. That's also a period of time where that culminated in Louisville's winning the 2016 Culture of Health Prize from the Robert Wood Johnson Foundation for the innovative work in population health that's been happening in the city of Louisville. So I think that prize-winning effort is in no small part due to the work of Ted and colleagues happening there in Louisville. More recently, he's been in the health technology startup world as currently CEO of Revon, which is a relatively new, I think, health technology startup, and we may hear a little bit more about the work that's happening in that space as well. So thank you so much, Ted, for joining us today, being willing to be with us in person here at Kentucky, as well as virtually throughout our national research network in Systems for Action. So I will turn it over.
All righty. Well, good afternoon, everyone. Thanks for coming. This all really started out as a harmless, I'd love to come over and learn a little more about your health networks work, Glenn. And then it turned into, like, we're happy to give a talk while I'm here. And then it sort of turned into, well, why don't we have a talk and have a webinar with people all over the world listening or whatever. So it's fun. I like the way you guys roll around here. It's great. So today I thought I would share really something, as Glenn said, is an effort that was born out of civic innovation and my time working for Mayor Fisher in Louisville. I joined his administration, 5 months in, after he was sworn in. I was living in D.C. at the time, and I moved back to Louisville to do that. And it was a very exciting opportunity. It's fun to be with a newly elected person because, and by the way, not a career politician, so first political job Mayor Fisher had ever had, because everybody sort of doesn't know what they're doing. And I think those are really special moments. And so not knowing all of your life stories, here today, I've always had the best experiences in situations that have all the sort of safety of new. And so I believe that the project that I'm about to describe is not possible in, sort of hardened, sort of tradition-laden organizations and institutions. So I think this is a special set of circumstances in many ways that made all of this possible, and I'm grateful for those too. I've got many other folks that really deserve some credit here, but I would truly be a con artist if I didn't give credit to Veronica Combs, who's currently the executive director of the Institute for Healthy Air, Water, and Soil, which is the grant recipient of the RWJ funds that have paid for the expansion of the work that we started back in 2011. And a lot of these slides I've stolen from her, so now I'm giving her credit. Veronica, you're welcome. Thank you, too. So you probably guessed, just based on the description of the talk, that we're going to talk a little bit about asthma. And a lot of work in asthma kind of feels, I don't know, kind of dutiful, kind of, a lot of it's surveillance work. What is the burden of asthma? What are all the determinants of asthma? What are our asthma management programs? How much of it is a matter of public health, and how much of it is a matter of healthcare delivery? Right away, we can all go to sleep, and probably should. That's not the orientation that we're actually going to come at this from. While all of this is true, that there's a real issue in asthma, a lot of it related to just essentially how poorly people who have the disease understand the disease that they have, understand the role the medications that they need to take play, understand things like environmental triggers that could be really important to them living well. For me, it starts here, and I know the room's a little lit to not see these two white guys on horses who have just stumbled across the Ohio River Valley. Because when I started my job in 2011, not being a public health professional, or even a health professional for that matter, and a mid-level executive at one of our largest companies said, we're having a hard time relocating people to Louisville because if they have asthma, or their kids have asthma, or their spouse has asthma, they know not to move here. And I'm not here to tell you I heard that story once. I heard that story a lot. And then sort of the more people you say, hey, did you know that there's something about allergies and asthma and here that's different than in other parts of the country, regularly people will recognize that. And they say, yep. And then the next thing they will say is it's the Ohio River Valley. Okay, so the Ohio River Valley is 203,000 square miles. And so I think if you were to live in some super dangerous, toxic place that was that large, we would all know about it in the country, and that it would be written about extensively and studied by all. But in fact, it's not. And so when I went to the health department, colleagues, I was this innovation guy, free range, just troublemaker, free radical in the system, right? And so meeting people who have legitimate careers, who need to do those jobs well, show up at the health department and be told by the health department that it's the Ohio River Valley and people just need to take their medications. And I guess there was just something deep in me as a technologist, as a cognitive scientist, that had a hard time imagining that the geography alone was the problem, as if it was an equally distributed problem throughout the entire Ohio River Valley, and it's the valley's fault, right? And, woe be you if you have to live in this valley, try to get out of the valley, live somewhere else. And so I happen to know from some time I spent in Washington at the U.S. Department of Health and Human Services that there was a technology that could help us see asthma attacks as they occur. And there was a wonderful young company, now called Propeller Health, was called Asthmapolis at the time, and they had essentially invented a device that's in market today that is a little button you put on the end of a rescue inhaler, and when you take a dose of your medication, it takes a snapshot of sort of what time it is and where you are. And so you can imagine how powerful that might be to have a very accurate record of all of these events. And so if you wanted to answer the question, is it the entire Ohio River Valley or isn't it? You might be able to answer that question with this. You couldn't do it with the diaries. Trust me, the diaries were highly problematic. Diaries for asthma only tell you about how compliant people are, using diaries, not something actionable that creates actionable data. This is hard data. A machine gathered it. It's good. You're good to go. We don't have to worry about any sort of error introduced by the patient, really. So that's sort of the premise. And so I want to take you all the way to the end of a pilot. And so in 2012, some good-hearted philanthropists in our community, because we can't use taxpayer money to do just crazy experiments, okay? Any of you who know anything about public policy, you can't do crazy experiments with taxpayer money, okay? So philanthropy is your best friend, right? So you need organizations that have the interest in the patients, or individuals that have the interest in the patients with their money to help you do those things. You know, now I'm in a startup company. You know, the private equity and startup means, you know, you're taking people who have the ability to lose money because they want to, you know, see something transformational happen. In the public policy side, I've found philanthropy often plays that role, whether it's Mike Bloomberg on a large scale, or whether it's, you know, any of hundreds and hundreds of smaller foundations, individual family offices. These are the people that put that seed money on the table that help you learn a few things. And so in our case, in 2012 and 13, private philanthropy put $150,000 on the table, and that enabled us to buy 300 of those smart units. And we had a partnership with Walgreens, and when you went in to get your medication, your rescue medication, you got enrolled in a trial, right? And you got a device, and you get home, and when you take your medication, you're sending signals to the cloud about where you are and what's happened. And so this heat map at the end of those 300 residents in our community roaming around their daily lives, the hot spots, right, the darker the red, the more events, the more rescue inhaler events, you know, the lighter yellow, fewer, and then obviously when there's no color, no events recorded. And, you know, we put on this particular map, you know, things that people like to think about when they think about population health and asthma. They like to think about stationary pollution sources, right? So all of the red dots are essentially stationary emitters of air pollution. We have the roadway system that goes all around. And so, you know, we have a couple of interstate systems that go through the city. So you can get sort of an orientation around it. You know, is it proximity to a roadway? For those of you that don't know Louisville well, on the west side of the community, we probably have more of our distressed census tracts. So there's older housing, it's just more poverty overall. So you have the dynamics of individuals who probably, just by the nature of the healthcare system, probably also have a higher burden of asthma. And so, you know, there are many people who look at the map who are very familiar with Louisville and immediately look west, and they want to know, you know, that's where all the asthma is, right? Because that's where all the old houses are with all the mold, and that's where all the, right? Turns out this map caused a lot more, it generated a lot more questions than answers for everybody. And really good scientists, and there are many here with us today, you know, are happy to throw out the, well, what good is a convenience sample? You know, like, how did that really work? Who really came into this study, and what were they, you know, how did you control for? Of course we didn't do any of those things. We had $150,000 in, you know, a couple of months, and, you know, we just wanted to see if it was the entire Ohio River Valley, right? And if it was the entire Ohio River Valley, we wouldn't have had that. Okay? Just throwing it out there. By the way, this isn't where people live, just to be clear. I mean, if you want to just say, well, you didn't learn anything, I mean, I can tell you where people are concentrated, and it's not under those blotches, except for maybe that one, and that's downtown during the day when you have a whole bunch of people there. So, again, more questions than answers, and that is why we are forever indebted to the Robert Wood Johnson Foundation, because when they saw that initial heat map, and they saw that we had convinced a whole bunch of citizens to walk around with a device and share their data with the city, right, with the government, for God's sakes, right, that you know, could be the beginning of a whole new era in public health and in population health. And I know that's a big statement, but I mean, it is also true, you know, that if we can shift the paradigm from, you know, enrolling people in secret studies where we observe them and then later we, you know, share the proceedings at a conference and then we publish the paper, we're a long way from getting to changing anything, right, in a mold that works like that. And so this was, well, heck, if you can get people that are the vested parties, the people who suffer from asthma in your community, and there could be anything that is public policy that drops out of the other end, then you've already have a base of advocates, right? They were in your project, and it was a public project. Everybody knew about it. The newspaper wrote about it. I mean, this is a sort of a perfect, you know, formula for if there's something to be done, there's something valid to be learned and be done, then the will is already there. And I do think the wisdom of RWJ for, sort of looking at this as a special situation. You have the mayor of a city getting behind a learning project that was very public, that advertised that we're a terrible place to live if you have a breathing disorder, right? I mean, that takes great political courage on top of it all to go out and commit to that. So RWJ said, well, this is sort of I think kind of a really interesting opportunity, but can we actually get to those kinds of big statements that you're making, right? Can we get past the objections about the size of the study? Can we get to a place where public policy is an easier conversation to have, right? Because you can't change policy affecting 1 million people with 300 conveniently grabbed people for 12 months and a couple thousand rescue inhaler events. So they're kind enough to support an expansion of the project. So over 1,000 participants, 2 years in length, and really to formalize the stakeholder engagement. And so I won't spend a lot of time on it today, but the really interesting thing from a philanthropy perspective that RWJ did was they insisted that we also engage employers in our community because they had an eye towards sustainability. So, if you're the Robert Wood Johnson Foundation or any other philanthropy, the worst thing that can happen is, we just have to keep doing this forever, right? Like I have to keep coming back. Like we lost all the units we handed out 2 years ago. We need more units, and forever you must write us checks so we can hand these things out to our people. I mean, that makes no sense, of course. And so the wisdom to say, well, if you get some employers on board and you get their employees in the system and you show them that it works just for the health of their employees, the technology alone just for the health of their employees has value, then maybe they'll agree to make it a defined benefit in their health plans. And then if enough employers in Louisville made it a benefit, then, and if everybody was still excited about sharing information when it made sense, then we would have a sustainable surveillance program, right? So, that's why you see name brands that many of them are very recognizable name brands who agreed to essentially, put this in their wellness fair for their employees as something that they could sign up for and get for free because it was being paid for by the grant. And then we did some general public solicitation, Facebook, all kinds of stuff. So it's a whole bunch of different entities who are coming at it from very, very different perspectives. As I told you, over 1,000 participants, which was certainly over the goal that we set for ourselves. The distribution of those participants, over-indexed on African-American population. So in Louisville, we're about 20% African-American. In the study, 30% of participants were African-American, and the rest of it actually comports to what our demographics look like. Spatially, I know this is not a great map of Jefferson County, but it is generally the outline of the county where the colors are darker, a little bit into southern Indiana, a little bit south of Jefferson County. So it's spatially representative, overweighted a little bit in West Louisville, which is part of the why we have 30% on the African Americans. Okay, age across the board. Asthma is a disease that affects everybody, and there's special versions of it that are pediatric. They're very concerning, and there's geriatric versions that are very concerning, and then there's the everyday versions that many of us have. Gender, a little more female than male in the study. Everybody was excited about using their phone. Some participants who didn't have phones were given a Qualcomm hub base station, and so that just enables the propeller unit to just talk to the base station instead of needing a phone in the loop. Okay. One of the things maybe we all shouldn't be surprised, the vast majority of people that came into the project had control issues with their asthma. The vast majority of people with asthma have control issues. So there's no reason to believe that this looks any different than the world at large. But it's important to know because this is one of these variables that we ultimately affect. And then the last thing I think is kind of important, when you ask people why they want to be part of the project, you're not surprised that they want to get better control over their asthma. They want to suffer less. That makes a lot of sense. If they can learn something, right, about triggers, we knew that was part of the proposition for them. But, number 3, I want to support a community project. Nobody needs to tell you that, right? I mean, that's a highly individual kind of a preference, right? Do you care about helping your community or don't you? And, from our perspective, this is what helps people like the mayor continue to be excited about this, right? Because it's one thing to say, oh, population health, it's everybody's problem, but it's really not everybody's problem until you find a way to involve everybody in the problem. And so this is an encouraging data point. It says if you can create a way, a mechanism for people to be involved in their health and make it a community-wide effort, not just handing out pedometers, but this is asthma, and this is a serious issue, that they will take that challenge. And, I think there's a whole lot of different kinds of chronic diseases that, we really could be looking very differently at through a community lens rather than through a private individual patient and the secrecy and privacy of their own home with the confidence of their physician and all the stuff that keeps it from being truly a population matter, truly a community matter. We definitely see inklings of people, they're not as freaked out about their health information as you all think they are. They're not, I promise you. And then, just a little bit on the technology. I said it's a little button that pops in on the end of that inhaled medication unit. There's a lot going on in the technology where they're essentially given feedback about how well their asthma is controlled. And so if you lean on your rescue medication too much, you're going to get a notification that says, hey, are you taking your controller medication, as prescribed? Hey, is there something going on in your life right now? I mean, there's the beauty of a closed loop just for the individual means that this study, while you could call it an asthma surveillance study, also was an interventional study because we gave individuals who have a disease technology that could help them have fewer bad effects of that disease. And there's part of me, and I'll just confess it right now, if what you're looking for is a signal of people that are suffering from a disease and you hand them something that helps them have less of the disease just on their own, it's not really helping you on that first agenda, right? But this is actually what makes it powerful, is we know even though people were getting better at controlling their asthma, while they had this technology in their hands, there's still enough signal in there for the rest of us to work with. And so it's a really good deal, from my perspective, all the way around. We've seen a lot of backlash to academic studies of health in our community. It's actually one of the first lessons I learned working for the mayor is, if you'd like to come into West Louisville and study how healthy we are, I'll just tell you we're still poor and we're still sick. You don't need to study. And, people have said those things. Like, we're done being studied. We actually need help. And so, I think there's another sort of undercurrent in this work, which is, if there are methodologies empirically that we can all get excited about, it'd be helpful, if there was a way to actually alleviate the burden of disease while we're studying it. So that's a little sort of side note. Let me skip through here. So clinical outcomes, just for participants. We're not talking about what the community gets, what the individual gets. So across the board, 74% decrease in rescue inhaler use. And so, again, if we're trying to look at rescue events, we're making them go away just by handing them this technology. They're getting better control. Asthma-free days. So, that number goes from 30-ish% up to 65% asthma-free days, the longer you're in the project with the technology. So, obviously, there's something in it for the people in the project. And then they all report, they've got a better handle on their asthma. They're glad they have the technology in their hands. The community side, of course, is the thing that I'm most interested in, and that is if you were to aggregate all of these events and look at them, what might you learn? And so what I told you we know, sort of what time it was, where you were, the dose of the medicine you took, and the medication specifically that you took, and then we can bang that up against all the other data that we can possibly find. And because this is a spatial study, a spatial temporal study, you're just looking for anything that describes what's going on in Jefferson County, right, at that time, at that place, anything we can know. And so it's a really wonderful sort of big data project at that point in time. I've got an anchor signal that now I'm trying to correlate and regress against all sorts of other things. Now the cumulative hotspot map looks something like this, which, looks a little bit like breakfast or a Rorschach, but it is essentially downtown and down into the university, and then something in the east where there's some industry, not a lot of industry. Our large corridor of industrial manufacturing is on the far west side of the city, Rubber Town, right? largest collection of chemical companies making rubber. That's all over there. So that's not on the east side of town. The east side of town is generally wealthier suburbs. And so there you have it. So we have something to puzzle over. If you then go run all the analytics against it, and we've published some of this in this article, Environmental Health Perspectives, you see some of these variables start to pop. Temperature, nitrogen oxides, pollen, smoking, and then small particulate air pollution and grass pollen. Many of these things aren't all that surprising to anybody, and if there's any allergists in the room, they've always seen this kind of relationship with parts of the country that have high pollen issues or going to have asthma exacerbation issues. But there's not a lot of published literature that shows relationships with air pollution, other than in just the very abstract sense of if you're in a vulnerable population, if you have vulnerable airways, you probably shouldn't be near people that smoke and any kind of irritants in the air. But systematic connections between small PM and nitrogen oxides, that really has not been studied spatially. And so that was sort of new coming out of that work. So this is based on the first tranche of patients. So now you can start to build essentially a spatial risk map for our community. We know about all these background variables. Now those background variables are risk factors. And now we can start to ease our way toward a public policy conversation, right? So we understood what the disease was. We understood what the events were that we were, very concerned about. And then we understood what the correlates were. And now we're hunting for those correlates. And how might we, the public sector in that case, actually have any impact on those things? Now, obviously, things like smoking, we've done our part. We continue to work on, smoking bans, e-cigarette bans, all those kinds of things. We're all working hard. Kentucky has a lot more work ahead of it in that regard. But, things like air pollution are not the kinds of things that anybody's working on as it relates to public health. And so one of the great interests that I've always had in this project is if we could connect the world of population health with the world of environmental determinants of health, and which are essentially managed entirely independently in this country. The Environmental Protection Agency is strictly enforcing the Clean Air Act. They know nothing about human health, other than when they had to establish the guidelines, somebody told them where to put the guidelines. But then they know nothing about health again, right? And so you can't rely on air pollution monitoring in the United States as some sort of proxy for protecting the public's health, because that isn't what they do, really. It's not what they do. And then you have public health departments who say, well, the EPA decided whether the air was dirty or clean. That's not something I know anything about or do anything about. And so literally you have a problem that is not owned by anyone that causes known suffering, right? And so a lot of the policy work that falls out of this is really to focus on how do we look at sources of air pollution as a very practical matter, and treat it just like we started with the premise that it's not the entire Ohio River Valley, it's not all pollution, that potentially we live in a part of the country where, and this is the only hat tip I'll give to the Ohio River Valley, where it is possible that we concentrate things, pollen, air pollution. It happens in the Front Range of the Rockies, it happens in Southern California in the Valley, it happens in Pittsburgh, Cincinnati, and Ohio every day of the week. And then you say, well, wow, so that must mean there could be parts and places that are potentially more problematic than others. And so that air pollution standards need to now take a more kind of flexible and fungible frame, not just the standard for the country is, and I measured it, because maybe we're accumulating it in different ways in different places, and maybe these stationary monitors they have aren't sufficient to figure it out. And so we've really been now hunting on, where are the opportunities to mitigate air pollution? Where are there opportunities to measure air pollution differently as a very practical thing that we could do? There's plenty of other work to be done in asthma, and the study certainly points to lots of other things to focus on. But the public policy conversation that we'll kick off next week at the close of this, essentially at the close of this funded study, is there will to go chase interventions based on the data that we have to date, based on the data we have from these events that we've captured, are we willing to go plant trees in parts of the community that are barren, that are also subject to higher concentrations of air pollution? Are we willing to do that? Are we willing to change housing policy to pull vulnerable populations away from congested roadways? Are we willing to, and it's a long list of things that would be real, crunchy, satisfying. We know why we're doing it. We know the extent of what we're doing, and we all could be directly involved. And so I'll just give you sort of a closing table of a way that you can back certain kinds of interventions into rescue inhaler events. And so, if I bump up the tree canopy, I get a certain number of rescue inhaler events back, right? If I can reduce NO2 and PM point source issues, I can reduce another couple 100,000 rescue inhaler events. And so there's a kind of a currency that emerges, and then I can back rescue inhaler events into total medical cost if you want to do that. And so now we're having a informed conversation, right, with real chits that we can count and then decide, what's it worth? What's it worth to invest in green infrastructure? What's it worth to invest in zoning policies? And we have a currency to back it out of. So I will end with that and happily take any questions that anybody might have about the project. Oh, thank you. Come on.
So, Ted, hi, Mike Childress. Did you throw in something on the right side of the equation, the environmental factor? It doesn't really help get to policy levers. But I'm, as a person with asthma and a father of a couple of kids with asthma, I see and understand and feel the role that stress, amorphously defined, plays in causing these attacks. I mean, anything you could throw in on the right side of the equation, the local unemployment rate, the latest U.S. scandal, anything.
I see. It's going to be one of those questions. So we didn't measure any of that specifically, so I won't make up an answer, other than to say, as you know, these diseases are an amalgamation of all kinds of things, and so what I'm trying to do in the way that I think about the work is separate those things that can be the responsibility of the public sector, can be the responsibility of the medical community, can be the responsibility of the individual, right? You bring up like the psychological well-being is really an important and tricky one, and I think it's really interesting in urban environments because we essentially have a work arrangement and a living arrangement that is pretty unnatural in terms of what our biology was really set up to do, and so I just don't think we even have the tools to start unbundling that stuff. Like your job and the way it works is a pretty artificial situation, and probably much of the stress of your biology is determined by the nature of your work, the places you work, how you get around, the daily life that you have. And I think there's a whole bunch of people that are sort of on the sort of the built environment side who touch work and workplace design, all those kinds of things. I hold great hope that we're going to figure out how to learn to live in cities and learn in to live in more dense environments, because it is clearly exacerbating any number of things. I mean, you look at cardiovascular disease alone, which kills everybody. There's a lot of lines you can draw to factors like that. They are really difficult to measure. At least it's been our experiences. How do I really get a handle on that? I mean, someday, Apple Watch 7, may have like a perfect image of how you're doing today, right? And I hope for that, I guess. But in the meantime, that feels like the frontier that we're just not quite there with yet, really. I mean, when we grabbed a very broad cross-section of people. I mean, I like to think of it as like the grocery store test, like who you're going to be in line with in the grocery store, just other people that need food, right? And that's everybody. And I think that's the safety we took in the study. There's a lot of researchers who spend time on disadvantaged populations, and that's all good and fine, except for when it doesn't help us then address broader issues that are common to everyone. And I was lecturing Kara on the way over. Public health used to do ambitious and important things, and then one day they stopped. And so, my hope is that we can make sure that drinking water doesn't kill you, that we can make sure you know why vitamin D is in the milk, right, so you don't die, why you have iodine in salt. I mean, these were things that public health used to do to save hundreds of millions of people. And I really feel like we've drifted as a discipline, I think too much influence by physicians, no disrespect. It's turned into caregiving or, case management or I don't know, something. And I'm really hopeful for us being able to put the big things on the table. I mean, we should have a city that supports the health of our community, promotes the health of our community. That's what the city should do. And instead, I feel like we get caught in remediation. I mean, even my talk, we have to remediate the damage we do to people. And that's not such a strong place to start. It's better to put the vitamin D in the milk, right, than to treat all the people with the vitamin D deficiencies. Super expensive to treat those people, right? So much cheaper to put it in the milk. And so we need a lot more of that on that question, so that when unemployment goes up, that we're not all helpless to, oh my gosh, my life was terrible, now it's twice as terrible. There has to be something health promoting about the places we are that give us that resilient protection from the things that happen to us. It's a great question. Other questions about the work?
You mentioned kind of the sustainability strategy that makes into the foundation.
Yeah.
Can you tell us how that's going in terms of employer engagement and other signals of sustainability?
Yeah. So it's not going as well as we'd love it to go. One of the great challenges with these projects is you want to get it sort of powered up. You want to get all those people in. And the sales cycle of working through companies at a time and their health plans and their benefits and the people that are involved, it turns out we probably needed to start a year and a half earlier if we really needed aggressive engagement with employers. So what we got were some pioneering employers with smallish groups of their employees. And so we're in the awkward position of, is there enough power in the employee group to have those employers feel comfortable that this is a great thing to add to their benefits plan? It's not clear, how that's going to play out. I wish we had more participants from those companies. I wish we had more companies. But that just wasn't the design of the project. That's my cop-out answer. But I do think if you think more broadly about innovation in healthcare, we didn't have to wait in a long line to meet with that HR manager. It wasn't like there were 15 other technologies or interventions that we were, being considered against. We were the only ones meeting with these people. And so the part of me just wonders if maybe we're attacking the innovation agenda from the wrong angle. There's a whole lot of energy that goes into, well, if I'm an innovator and I've got some promising population health technology, who do I need to go talk to? And I don't think they would say the largest employer in town, right? And so, I think, so then the employers aren't trained to think they have any role in this problem either, right? And so they're used to wellness programs for their employees, disease management that their plan administrator told them to talk to, and so there's not an obvious pathway there. So, I'd love RWA or somebody to sort of look at how you open up that interface so that employers who are truly vested in places, right, truly, they care deeply about the people who work for them, and they want them to be well, and they want their families to be well, but there's not an easy way to engage with them at this time. So I don't know where it's going to go on the sustainability front. I'm hopeful that, again, with technology, prices go down, things become more pervasive. Some of this may just be, this particular situation with this equipment, maybe that's it. And maybe that's, we just have to get to a place where it's just a lot easier and it's like water. I joke about the Apple Watch, but it just keeps chugging along and it just keeps doing more. In 2 years, it does oxygen saturation. I'm the happiest guy in the world for my company if your watch does that well. Just happy, right? Because that's just one less thing we all have to figure out how to pay for and how to roll out and implement. So, I think some of this is strictly a matter of timing, and some of it is just structural to remind employers that they really do care about the communities that they're in, and that they really could do something about it. But we're just not quite there yet. Wish I had a better answer for that. The payers, I also hold hope that, so if the employer can't figure it out, maybe the health insurance company can figure it out. But that's still early, too. I mean, only recently, I think, you've seen some insurance companies say, I really have to start figuring out how to do the right thing for all these individuals because I might have them for a long enough time where if I do the right thing, I'm going to get the benefit for doing the right thing. And that didn't used to be the case in insurance, but I think increasingly they're starting to operate in that way, and I hold great hope for that working out. It's a great question. Other questions?
I have 3 questions from online.
Okay.
So 2 are related to triggers, and the first one actually relates to somewhat what you were speaking about sustainability. And said you had showed us a slide about different ways that reduce rescue inhaler use, decrease costs, et cetera. Many of these ways will take time. For example, reducing emissions, smoking, tree canopy, and what can clinicians and patients do to help advocate for these initiatives?
Yes. So one of the things on the clinical front that I'm really very optimistic about is, if this can be reduced to things that feel like guidelines, just accepted practices, and that if you are asking questions of your patients about things like proximity to roadway. I mean, we worked with a number of pulmonologists over the course of this project, and it is not a standard medical history question to ask, do you live near a congested roadway? That is not a question that is asked. That's not a question that any EMR system calculates for you, on its own. And so it turns out if you know that could be an important thing to know about that particular vulnerable person, that can open the conversation. Now, I don't know exactly where the conversation goes, whether it's an HVAC conversation, an air filtration, whether it's maybe you should think about moving conversation. Maybe you need to really take your maintenance medications very seriously, right, because you live in a situation that's, hostile to your health. I have great faith that clinicians are the best people to have those conversations, to really put the disease in context. And, so much of medicine has been plagued by just your patient, you exist as a patient in isolation, and now we know patients live in places and they have issues of daily life in their places, and we need to start bringing that stuff in. So I think it's highly actionable to say there's pretty good evidence coming out of Louisville that proximity to roadway is a question I should probably ask somebody about, really on these triggers questions, do you want to try a monitoring project for some period of time? I mean, these technologies, they're not that hard to use. And, even for brief periods of time, many of these patients figured out quickly what their triggers were, just because the data would just pop up. Like, the system interpolates some on its own. Like, I noticed you were here, and you had an event, and you were there again, and you had an event. I mean, the technology can be good at remembering things you can't. So it's a great question.
Well, in triggers, I think you kind of somewhat spoken to. One was I'd like to understand how how was asthma risk calculated as a function of the triggers listed. And then the second question again was about the triggers was, are you able from your data to parse out what proportion of the variability in asthma exacerbations is due to medication, non-adherence, socioeconomic hardship variables, environmental triggers, et cetera?
Okay. So, on all the other sources and that drive exacerbations, some of the obvious ones we tested for. So socioeconomics, absolutely tested for. Age of housing stock, all those kinds of things. So we could go in and adjust for events by those variables, not on the short list that I shared with you of things that were harder determinants at the P.05 level. Now, clearly, we could have just done a study on poverty, and we would have seen a lot of those issues be very prominent. That said, again, we're working the whole size of Jefferson County and trying to figure out at a county level what can we do. So then we didn't study medications specifically and issues that people had with medications. And so these are the variables that we would just let kind of vary on their own. Not much on mission with what we were trying to do. Like if you want to do a medication study, there's a way to do that, and there are a lot of companies that are interested in the way those are done. But we were really trying to get a community project done, so we were really just focused on triggers that we thought somebody like the mayor could do something about that were statistically significantly related to the events. I know you have a question.
Not the Ohio River Valley, I guess.
Well, it sort of is and it isn't. But it is to the extent that maybe some of these environmental factors need to be adjusted for places in the country, or even microclimates, microplaces in cities. And so that's the lesson on the Ohio River Valley is, maybe it is, but it's really not in the way that you thought it was. It's not you live in a bad part of the country and move to a different part of the country. It's not that. It's something a little more nuanced. And it's something that I think we all, at least on the public policy side, we could get excited about working on because it's winnable, theoretically.
So while you have just individual, but you have great individual data on use of inhalers for triggers, how does this more locally epidemiology-wise from your map fit with concentrations of asthma, because we have some maps of those in other urban environments where there's low tree coverage, there are higher rates of asthma next to, and then that brings you back to Grady Memorial Hospital, which is next door to a 16-lane highway. And there were housing literally stones from it. And I also remember being told, oh, if you're 10 feet away from the edge of the road, you don't get so much pollution, which obviously is a myth. Some of those.
Yeah. I mean, look, there is plenty of sort of the worst kind of post hoc analysis of places. And there's plenty of it, right? There's plenty. I can give you 100 studies on trees and asthma. And by the way, plenty of them say trees cause asthma. Because trees emit volatile compounds. It's, there's no magic situation here. So, when you look at these interventions, I think you really have to have a theory of the work, a hypothesis driving this, right? Because you can't reduce it to overly generalized situations. So the roadway stuff, there's plenty of literature out there that says, proximity to roadway, it's a big no-no for cardiovascular. You want a heart attack, you go live next to a busy road, you get a heart attack. Certainly in asthma and COPD, it's not helping. And so, we think using technologies like this create a kind of an economy around it where we can maybe make better policy decisions. Because the problem with all that post hoc science has been, generally speaking, living near roadways is generally bad. It's not always bad, and it's not deterministically specifically bad. It's just generally kind of bad. And then policymakers sit there and they say, well, it's generally bad and it's not specifically bad. Why do I have to specifically do anything? And this is a problem. Right? So even if I was picking on the Clean Air Act earlier, decades and decades of established research on exposure medicine because the first 10 studies weren't enough. And then the next 200 studies weren't enough. And so the sort of nuance for me is if I can get you down to some kind of calculator like rescue inhaler events, super simple slot machine math, right? Like how many times did you hit the inhaler? That starts to then create a very specific situation, right? And so if I live in a dream scenario, everybody living near the roadway also is popping off units of inhaler use. And then the people that live out in the countryside, they're popping off inhaler units too. And then we can say, well, look at that. And it creates an imperative. And to me, that's what's been missing in a lot of these conversations, especially around public policy. There's no imperative. It's generally good. If I can get around to it, I'd like to work on that, and because there's no accountability and there's no measurement, you can wait a very long time. And on the civil litigation side, that science isn't good enough to win in court, and I'm sure you know that. So public policymakers are also very aware of, well, what would the burden of proof be if somebody were to come into town with a bunch of lawyers, and it turns out it's a very difficult burden of proof to establish. And so I think these technologies are starting to color policy in a way that public policymakers don't see. That they really need to be grabbing onto, not the issue. I don't want to talk about air pollution and asthma for the rest of my life. I like the specifics of the solution, which is now I'm giving you a way to decide what's it worth. How much of your political capital is it worth? How much money from the taxpayers is it worth? because we've got an individual in our community who is trying to restore our tree canopy to 40% from the 26 or whatever it is now. That is a couple $100 million of trees. I'm pretty sure we're not going to do it. I'm pretty sure it's just a lot of money. And so, an argument that we should have a tree canopy, because good, healthy places have tree canopies, it turns out to justify $300 million, you need more than good places have tree canopies. And so, we have a great exposure medicine person, Dr. Rudy Bhatnagar at the University of Louisville, and he's just been really good at trying to equate some of these exposures to what is the effect of statins. So it turns out if trees can pull a couple micrograms of small particulate pollution out of the air, that is the equivalent cardiovascular protection of all the statins that are prescribed in our market. Okay, well that's a couple $100 million. There you go, a couple $100 million a year. Now we got trees. So I think a lot of this is a lot more pragmatic. It's not ivory tower kind of, are we smart enough to figure this out? Are we capable of producing the proof in a way that people can operationalize it? That's the single biggest problem we have right now. I believe it. And, I'm very sympathetic to public policymakers. I think it's a very difficult job. And, so you have to sort of give them what they need. You have to give them the proof of the argument and the comfort to know that the whole community is behind you, right? And they want to see the right thing done too. A lot of especially the environmental justice issues we've been facing in the country, is just strictly laissez-faire economic development. We don't have any rules. We don't have any reason to have rules. Build your factories wherever we have cheap land. It's just, it's not a very thoughtful exercise. And now we're paying for it on the health agenda. As a country, that's all we have left right now, right? GDP is, what's health? Is it 28%? We'll just be health as a country. Well, that's how we'll be paying for everything. And so I'm sort of comforted by that, right? Because then economic development could be formed by health, right? You want to attract a Range Rover plant here? Okay, well, let's figure out what that's all going to add up to. Are we going to win or lose, generally speaking? And is there a better way to do it and a worse way to do it? That's the beauty of health. And I honestly think public health should own it. I really do. That's my challenge to the University of Kentucky. I think they don't want to hear it move out. Other questions? All right.
Thank you so much.
Oh, thank you.